In this lecture, we will cover the U.S. health system. We see the part of the core content that is devoted to this topic, which is fairly large. This slide shows in further detail, drilling down into the core content that is focused on the health system. This slide lists the key topics that will be covered in this lecture. We'll begin with the structure and function of the U.S. healthcare system. We'll look at current problems and proposed solutions for the U.S. healthcare system. We'll look at key Institute of Medicine reports over the last couple decades and the context that they set for informatics. And then finally, we'll discuss incentivizing the adoption of health information technology. This slide shows in more detail what we'll cover in the lecture. We'll first look at determinants of individual and population health. We'll look at the primary domains, organizational structures, cultures, and processes of healthcare. We'll look at the flow of data, information, and knowledge within the health system. We'll then discuss the policy and regulatory framework, health economics and financing, forces shaping healthcare delivery, and healthcare quality and improvement. Finally, we'll discuss the Health Information Technology for Economic and Clinical Health, or HITECH Act, and the so-called meaningful use of the electronic health record. There are many determinants of individual and population health. A more thorough discussion on this topic is presented at the webpage linked here. And we know that many factors influence individual and population health. For example, policymaking, government, whether it's the local, state, or national level. There are many social factors that are determinants of health, both individual and societal, economics, environment, education. Obviously, health services affect individual and population health, not only the healthcare system, but also public health. Clearly, individual behavior, diet, activity, lifestyle, and so forth affect individual and population health. And of course, there are underlying issues in biology and genetics that affect health as well. In the next part of this lecture, we'll look at the primary domains, organizational structures, cultures, and processes of healthcare. What does that actually mean? Well, we'll look at healthcare delivery, public health, clinical research, education of health professionals, and personal health. We often talk about the different levels of healthcare. It's important to distinguish them. Primary care is the initial and ongoing care that an individual receives, typically in an office or clinic. Secondary care is the specialty care that's provided in the community. For example, surgery or other kinds of procedures that take place relatively close within the community to where a patient lives. Tertiary care is highly specialized care that's usually provided by referral in a large, typically academic medical center, and quaternary care is sometimes used to describe an extension to tertiary care where there are advanced levels of medicine that are highly specialized and not widely accessed. Sometimes we think of these levels taking place at different institutions, but in reality, primary care and secondary care can take place in a center that also provides tertiary care, as there are primary care clinics, for example, in an academic medical center. Also important in the healthcare system and public health as well are the stakeholders, and for whatever reason, they all start with the letter P. So there's the patient, the one who gets healthcare, and this individual may be called a consumer or a citizen when they're well and they're not seeking medical attention. There's the provider, consisting of those who provide healthcare, physicians, nurses, allied health. There are purchasers, those who buy healthcare And in the United States, that is typically either employers or the government. There are payers. Those are the entities that pay the healthcare system for its care. These are typically insurance companies as well as the government. And then finally, there's public health, the protectors of the public's health. And of course, we know there are many problems with the healthcare system in the United States. One of these is that the U.S. pays more for all aspects of care relative to other countries. The one silver lining being that there has been a leveling of costs over the last 4 years, probably due in part to the recession that took place in 2009, but for whatever reason, the costs have been leveling off somewhat. The U.S. also has what some describe as a health disadvantage. Our life expectancy and infant mortality are among the lowest of all countries with advanced economies. Many also believe there's a great deal of waste in our system. There's overtreatment, such as overuse of drugs and surgery. There's failures of coordinating care. There's failures of delivering care, not carrying it out under known best practices. There's administrative complexity, a lot of bureaucracy, spending on insurance administration, advertising, and so forth. There are pricing failures when prices are above what might be reasonable for a market, and there are problems with fraud and abuse. We tend to focus a great deal on the healthcare system and sometimes don't pay as much attention to the public health system. Public health is the science of protecting and improving the health of communities through education, promotion of healthy lifestyles, and research for disease and injury prevention. This comes from a website devoted to defining what is public health. And perhaps one of the most articulate spokespersons for public health is the late Dr. C. Everett Koop, former U.S. Surgeon General, who noted that healthcare is vital to all of us some of the time, but public health is vital to all of us all of the time. The public health system has many functions and activities. Its core functions include assessment of individuals and populations, policy development leading to government laws and regulations, and assuring that businesses, governments, and others adhere to best public health practices. The particular activities of public health include the prevention of epidemics and spreading of disease, protection against environmental hazards, prevention of injuries, promoting and encouraging healthy behaviors, responding to disasters and assisting communities in recovering from them, and also assuring the quality and accessibility of all health services. Sometimes what distinguishes public health is its different perspective. Public health tends to take the perspective of the health of entire populations more so than individuals. One of the basic sciences of public health is epidemiology, which is the study of disease in populations. But public health is involved in many other activities, other forms of health promotion and disease prevention with focus on programs addressing obesity, nutrition, and related activities. The public health perspective then may result in a different perspective than individual care, where the population-based view focuses on preventing disease as well as the societal impacts of health. And public health is usually some sort of governmental activity, whether it's a regional government or the federal government for an entire country. Another domain of health is clinical research. research that consists of studies and trials in human subjects that attempt to determine what are the best approaches to preventing and treating disease. The government agency that plays a central role in clinical research is the National Institutes of Health, or NIH. When we discuss clinical research, there are three categories of it. One is patient-oriented research, that is, research conducted with human subjects or on material of human origin, such as tissues, specimens, and cognitive phenomena. And there is typically an investigator who directly interacts with human subjects, and they focus on areas such as mechanisms of human disease, therapeutic interventions, carrying out clinical trials, and developing new technologies. Other subcategories of clinical research are epidemiologic and behavioral studies, as well as outcomes research and health services research. Another aspect of research is translational research. This is the translation of basic biological findings into specific treatments that first get assessed in controlled, often academic settings, and then are moved out to the community. A criticism of clinical research is that there's a great deal of time that it takes for this entire process to occur, and so a focus of translational research has been accelerating research results from the laboratory to the clinical environment and onto the community. We talk about three different types of translational research on an axis: T1, T2, T3. T1 being the translation from so-called bench to bedside, of taking basic biological discoveries and turning them into human tests and treatments for disease. There's then T2 translational research that focuses on taking research out of the controlled academic setting and into the community, and then T3 research that focuses on optimizing the delivery of healthcare. All aspects of the research process require collaboration and partnerships, and of course, a good deal of it is facilitated by informatics. Another domain of the healthcare system is the education of health professionals. These are health professionals who work in fields like medicine, nursing, dentistry, pharmacy, allied health, and so forth. Most of the education of health professionals is done in professional schools, typically at universities, which have academic medical centers. The education of health professionals culminates in certification. In the case of medicine, there are 24 private nonprofit boards, and there are similar boards for nursing, dentistry, pharmacy, and so forth. Individuals get certified by completing training and passing an examination. Of course, that's not all that's needed to practice a health profession. They need to be licensed, and this is typically done through state governments. Another important aspect of health professions education is continuing education, since all of the health-related fields continue to change. New technologies, treatments, tests, and so forth come down the road, so health professionals must keep up. Historically, continuing education has focused on courses and credits, although in medicine there is a growing shift to what is called maintenance of certification, although this has also been controversial in some of its aspects. Another domain is personal health, and of course, patients are increasingly involved in their own health and encouraged to engage in healthy behaviors that aim to prevent or reduce complications from disease. The decision-making of patients around health has been studied, and some findings to emerge are that half of adults make healthcare decisions for others in their families. Often this is done by the woman who heads the household making decisions about children, elders, and others. 3/4 of the population are interested in information to help inform their decisions, things like knowing about their physicians, their quality ratings, experience, and so forth. Of course, much of the kinds of information they really might like are not available, and as such, they often make decisions in healthcare with little information. And even a half decade ago, we know that patients were interested in accessing their data and information, including by electronic means. All of the domains we've discussed so far involve a good deal of data, information, and knowledge. And a report from the National Center for Vital and Health Statistics enumerated the various sources of data about individuals. There are then users of that data from hospitals, physicians, patients, the public health system, payers, and researchers, and each of those users has particular usage as seen by the figure on this slide. Another perspective in looking at the flow of data and information to knowledge comes from the world of evidence-based medicine. We often think of evidence guiding clinical decision-making, and it does, but there are other factors that influence decisions too. There are preferences of the individual patient for one approach over another, preferences of the clinician, and there are also constraints. There may be standards in the community, there may be time constraints in terms of how quickly a patient can be treated, and there are also financial constraints in terms of the ability for the individual, the insurance company, or the entire system to pay for the care that has been decided upon through the clinical decision-making process. Let's talk about policy and regulation. A great deal of that in the United States takes place at the federal level, and the federal agency tasked with that activity is the Department of Health and Human Services, or HHS. The head of HHS is a member of the President's Cabinet. HHS has agencies within it, the Centers for Medicare and Medicaid Services, or CMS, which is the part of the government that pays for healthcare services, the Centers for Disease Control and Prevention, or CDC, that focuses on public health, the Food and Drug Administration, which regulates drugs and medical devices as well as constituents of food, and then the National Institutes of Health, which we've discussed already, that carries out biomedical research. There are also state and local government entities that address healthcare issues as well. Let's talk about the economics and financing of the healthcare system. There are different healthcare systems in different countries and different methods for paying the cost, whether it comes from the patient, from employers, or the government. But most healthcare is financed on the notion of insurance. Everyone pays into the system, and those who need it use it. The payment methods vary by country. There is private fee-for-service payment that is most prevalent in the United States, where physicians, hospitals, and others provide service and are paid a fee for that. They are typically private businesses. There are some entities that roll the insurance function into the delivery function, HMOs, preferred provider organizations. This is sometimes called private managed care. There is also government-financed payment for healthcare, so-called single payer, where there's still a private healthcare system, but the government is the payer. This approach is often associated with Canada, though there's a great deal of it in the United States through the Medicare system. And then there's government-provided care, which is typically attributed in countries such as the United Kingdom. How do we finance healthcare in the United States? One good source of information is the annual report called Healthcare Costs 101 that is produced by the California Healthcare Foundation. Some major findings from the most recent report are that total spending is now over 17% of the entire gross domestic product of the U.S., and in the future is projected to reach as high as 1/5 of the entire output of the economy. Per person spending on healthcare has more than doubled since 1996 to nearly $10,000 per person by 2015. About half of the spending growth is due to medical price inflation, the rising cost of providing existing services to patients, with much of the rest of the increase in cost due to the aging population. There are many payers of healthcare in the United States. There's private health insurance for most employed citizens and their dependents, although lesser so those in lower paying jobs. There's Medicare, the government's insurance program for the elderly and disabled. Medicaid, which is the government's program for those who are indigent. There's the State Children's Health Insurance Program, or SCHIP, which is another government insurance program for uninsured low-income children. Of course, insurance doesn't cover all expenses, and there are out-of-pocket expenses. There are also expenses for public health that are typically paid for by governments. We sometimes talk about the payer mix in healthcare, the percentage of revenue that comes to organizations from private versus government insurance versus self-paying individuals. This mix becomes important because Medicare and Medicaid typically pay hospitals less than the full cost of treatment of patients. This slide reproduces some figures from the Healthcare Costs 101 publication. It looks at the flow of money from the standpoint of the payer. So who's paying? We see private health insurance, public health insurance, and others. We then look at the contributors to the cost, be it from governments, households, and businesses, and then the category of spending, which mostly goes to personal health care, and half of that is made up of hospital care and physician and other clinical services, another 10% drugs, and then a variety of other categories of cost. What are the forces shaping healthcare delivery? Well, there has been much effort devoted to healthcare reform in the last decade or so, and as of this recording, the law of the land is still the Affordable Care Act, also known as the ACA or Obamacare. That may change in the years ahead, but for now, the Affordable Care Act is still the law of the land. There is much written about the details of the Affordable Care Act in various articles on the healthcare.gov website. Even though the legislation is massive, there are three broad goals for the Affordable Care Act. One is the regulation of coverage, so things like eliminating coverage restrictions such as not allowing coverage to be canceled due to pre-existing conditions, creating temporary high-risk pools. There's also major expansion of coverage, the individual mandate requiring individuals to have health insurance, the development of health insurance exchanges in the various states, employer penalties, and the Medicaid expansion. And a third goal is reducing costs, or at least bending the cost curve, reducing the growth of costs, and providing various incentives for higher quality, lower cost care. Of course, the Affordable Care Act was not the first effort to shape healthcare delivery or foster healthcare reform in the United States. There have been past presidents of both major parties who proposed comprehensive healthcare reform, Democrat Harry Truman in 1948 and Republican Richard Nixon in 1974. Another effort at healthcare reform was the passage in 1986 of the Emergency Medical Treatment and Labor Act, or EMTALA. This is the law that requires emergency departments to evaluate patients and treat any emergent conditions and not turn them away. There are many aspects of the Affordable Care Act, or Obamacare. Some of them are listed here. Things like tax credits for small businesses to pay for insurance, closing the so-called Medicare donut hole that required seniors to pay out of pocket for costs of drugs, requiring larger, greater than 50 employers to offer health insurance coverage to their employees, expanding the Medicaid system for low-income Americans to include all who live at 133% or less of the poverty level, creating health insurance exchanges, prohibiting denial of insurance for pre-existing illnesses. There were some tax increases for upper income Americans and also taxes on some healthcare transactions. And of course, the well-known individual mandate for health insurance that requires individuals to have insurance so that they don't seek insurance just when they get sick, even though many people do. There are plenty of politics around healthcare reform and Obamacare, and even though the conservative side of the spectrum is most vocal in its political disagreement with healthcare reform, there's really something for almost everyone to dislike. There are many left-wingers who lament the lack of a single-payer system, such as Medicare for all, or at least a government option that would let individuals buy into Medicare. There are complaints from right-wingers who argue about too much taxes and regulations, and of course, some desire to see all things Obama fail. There are also healthcare delivery policy wonks who lament that the legislation has too much emphasis on insurance and not enough on delivery reform. Part of the problem is that the politics are so toxic that rational debate is difficult. For example, the Kaiser Family Foundation has found that when you ask citizens about the specific components of the Affordable Care Act, they tend to support them, even though there is overall negative support for the law. We have political, perhaps can be called grandstanding, of things like end-of-life consultations, now being called death panels, and of course these aren't even part of the law. There are some conservative politicians who claim that the goal is to replace Medicare with the Affordable Care Act, But that would actually be a more conservative action because Medicare is single-payer socialized medicine, whereas the Affordable Care Act is regulated private insurance. And when you ask people if they dislike Obamacare or the ACA, more people dislike Obamacare than the ACA, and of course the two are the same.
Has the Affordable Care Act been successful? Well, certainly in one regard it has, which has been in reducing the rate of uninsurance. Over 20 million Americans who previously were uninsured now have health insurance due to insurance subsidies, Medicaid expansion, and children being able to stay on parents' plans until age 26. This has lowered the rate of uninsurance across the country from about 20% down to about 11.5 to 13.1%. A larger drop in the uninsured has been seen in states that expanded Medicaid. For example, in my state of Oregon, a previous uninsurance rate of 14% fell to 5%, despite Oregon having major problems initially with its health insurance exchange website. But really, the remaining insurance-related problem for the Affordable Care Act is the individual market. These are individuals who don't get health insurance through their employer or through any government program. They tend to buy individual policies and don't get the benefit of risk being spread across larger numbers of people. So even with the Affordable Care Act, the individual health insurance market continues to be challenging.
Despite the focus of the ACA on insurance, it does address issues of cost and quality. There are bundled payment approaches within the ACA, mostly implemented through what some call accountable care. Particular programs that are endorsed by the ACA are things like the Patient-Centered Medical Home, which attempts to provide a home for patients to get coordinated care, and also accountable care organizations, or ACOs, that provide flexible financial support in exchange to healthcare delivery organizations for accepting some amount of accountability for overall quality and cost. These are sometimes called shared savings. Many of these programs have already been in existence across the United States, and in the state of Oregon, for example, the entire Medicaid system is being reorganized under ACO-like organizations called coordinated care organizations. The ACA also focuses on quality, aiming to promote the use of care that works. One somewhat controversial approach to this is the Independent Payment Advisory Board, which is a federal agency that is tasked with changing Medicare coverage and reimbursement when cost targets are not met. And then the Patient-Centered Outcomes Research Institute, or PCORI, which is a public-private partnership that has been set up to support comparative effectiveness research, looking at tests and treatments in real-world settings and comparing them with each other to determine which are most effective.
What are the forces likely to shape healthcare in the future? Well, now that there is Republican control of all branches of government, we are likely to continue to see efforts to repeal and replace the Affordable Care Act. There are many plans and ideas that have been promoted. A well-known one is the Better Way plan that came from the Speaker of the House of Representatives at the end of the Obama administration, Paul Ryan. This plan looks at a variety of ideas that generally have a politically conservative flavor to them. For example, trying to introduce more competition into the private insurance market, having higher deductible plans that expose patients more to actual costs so they may become better at being consumers of healthcare. There will likely be replacement of government spending with things like tax credits, and also the use of health savings accounts, which enable individuals to save tax-free and then spend that money on health-related expenses.
Let's talk some about healthcare quality. We delve into this topic in more detail in a different lecture. And we'll talk about how the healthcare quality agenda has been driven by a number of reports from the Institute of Medicine. One of the drivers of healthcare quality is the triple aim, a term that was coined by Dr. Don Berwick, and consists of three aims of improving the health of the population, delivering better health care, and reducing the cost of both. When we talk about healthcare quality, there are different categories, and these are applied at the individual and organizational levels. There are structural healthcare quality measures. These are factors that make it easier or harder to deliver high quality care. Things such as hospital location, volume, amount of physician licensure, nurse staff levels, and so forth. There are also process measures that are factors that describe healthcare content and activities, such as adherence to guidelines for screening, treatment, and other activities. And then there are outcomes, which are changes that are attributable to care. So quality as measured by things like mortality, morbidity, and functional status. And again, we'll focus in more details on healthcare quality in a different lecture in the course. The healthcare quality agenda was driven, at least early on, by a series of reports that came from the Institute of Medicine and are mentioned explicitly in the core content outline for the clinical informatics subspecialty, probably because these reports advocated a number of informatics solutions and set in motion the processes for those to happen. This slide shows some of those early reports that were very influential in the agenda for healthcare in the United States and also the use of informatics to achieve that improved healthcare system. There was an initial report published actually initially in 1991 and then republished in a second edition in 1997, the computer-based patient record, which noted that paper records were illegible, inefficient, and error-prone, and that the computer-based record was vital to modern healthcare system. Another report called For the Record looked at protecting health information. It set forth a number of concerns about privacy and confidentiality of health information, and noting at the time that its protection was inadequate, and this report actually informed the HIPAA legislation that we now look to as addressing issues of privacy and confidentiality. Another report called Networking Health looked at the emerging internet and the role that it could and would play in health. Probably of all these reports, the ones that got the most press were first the To Err Is Human report, which brought to light the epidemic of medical errors, noting that they're common and are a systems problem, not necessarily attributable to single individuals. And then the Crossing the Quality Chasm report that developed a set of aims and rules for high quality 21st century healthcare. The clinical informatics core content outline actually calls out the IOM quality aims, and so they're listed on this slide. The Quality Chasm report basically stated that healthcare should be safe, so it should avoid injuries from care that's intended to help people. It should be effective, so providing service based on scientific knowledge and avoiding care that's unlikely to benefit individuals. Care should be patient-centered, so respectful of patients' preferences, needs, and values. It should be timely, such that waits and delays in care are reduced. It should be efficient, so avoiding waste of equipment, supplies, and energy. And finally, it should be equitable in that it provides care that does not vary based on personal characteristics of individuals. The Quality Chasm Report also defined a number of rules for 21st century healthcare. One of these being that patient needs and values should be the drivers of variation in care, not physicians, hospitals, and others. Care should be based on continuous healing relationships, so available 24/7 and using all modalities. The patient should be the source of control for healthcare decision making. There should be shared knowledge, free flow of information, and transparency of that information. The healthcare system should attempt to anticipate needs, rather react to them, and decision making should be based on the best evidence. The Institute of Medicine has continued over the years to publish many reports, and a number of these have significant informatics components within them. For example, the Knowing What Works in Healthcare report, introducing the concepts of the learning health system and of comparative effectiveness research. A report on the digital infrastructure for the learning healthcare system, what data and information systems are needed to achieve that vision. We also know that there can be safety issues related with health information technology. So the Health IT and Patient Safety Report focused on that topic. And then the Best Care, Lower Cost, which provided a comprehensive vision on how to implement the learning health system. Let's turn our attention to spurring the adoption of health information technology. This, of course, came about when the economic stimulus package was introduced and then passed in the early days of the Obama administration. President-elect Obama himself said in early January 2009, "To improve the quality of our health care while lowering its cost, we will make the immediate investments necessary to ensure that within 5 years, all of America's medical records are computerized. It just won't save billions of dollars and thousands of jobs. It will save lives by reducing the deadly but preventable medical errors that pervade our healthcare system." This led to the Health Information Technology for Economic and Clinical Health, or HITECH Act, which itself was part of the American Recovery and Reinvestment Act, or ARRA, or otherwise known as the Economic Stimulus. The HITECH Act provided incentives for electronic health record adoption by physicians and hospitals, as well as direct grants administered by federal agencies. The latter included $2 billion of funding, including $118 million for workforce development. The centerpiece of the HITECH Act is the incentives for the meaningful use of health information technology. Although this topic is not on the core content outline, it was covered in the 2013 board exam. The concept of meaningful use actually originated in legislation by Representative Rodney Pete Stark in 2010, and the idea behind it is that to meaningfully use EHR technology, there must be the use of certified systems connected for health information exchange and able to submit data on clinical quality measures. The idea was that if there was going to be U.S. government investment in electronic health records, it needed to have criteria so physicians and hospitals would not get paid just to install computers in their clinics and wards. The Meaningful Use program is set up so that all of the specific criteria map to one or more of 5 goals for the healthcare system. These include improving quality, safety, and efficiency, engaging patients in their care, increasing coordination of care, improving the health status of the population, and ensuring privacy and security. So examples are the criteria for implementing drug-drug interaction checks, which can be mapped to improving quality, safety, and efficiency, and provide the example of providing a summary of care to patients could be mapped to the goal of engaging patients in their care. The Meaningful Use program is implemented through the Medicare and Medicaid systems, and reimbursement through these systems is probably the easiest and most efficient way for the government to provide payment. There are 2 categories of those who participate in Meaningful Use: eligible professionals and eligible hospitals. The individuals who qualify for the incentives are different depending whether they come from Medicare or Medicaid, and the same applies for hospitals. The program has been set up to be implemented in 3 stages. These were initially 2-year increments, but stage 2 was pushed back to 2014, and then stage 3 was subsequently pushed back to 2017. In stage 1, the goal is for capturing and sharing of data, so basically implementing systems. In stage 2, the goal is for advanced care processes with decision support, and in stage 3, there will be emphasis on improved clinical outcomes. The amounts of incentive money vary based on whether one is reimbursed through Medicare or Medicaid. For eligible physicians, the amount of money is from $44,000 to $63,000, and for eligible hospitals, it's $2 to $9 million. These amounts vary, again, whether they come through Medicare or Medicaid. They also vary depending on the proportion of Medicare or Medicare patients seen, and then for hospitals also vary based on the number of discharges per year.
How was Meaningful Use operationalized? Well, stage 1 began in 2010. The objectives were announced early in the year, and the program began payments starting at the beginning of 2011 for eligible professionals and in October of 2010 for eligible hospitals. Stage 2 was originally slated to begin 2 years later, but it was pushed back a year. The objectives for stage 2 were announced in 2012, but it didn't start until 2014. Stage 2 raised the bar with additional emphasis of the Meaningful Use measures focusing on patient engagement and health information exchange. And then in 2015, there was an effort to consolidate stages 1 and 2 in the so-called modified stage 2. Where is Meaningful Use going in the future? Well, for eligible hospitals, they have moved on to modified stage 2, which again combines stages 1 and 2. And if the program remains, which is uncertain given the change of political leadership in the United States, they will be required to move on to stage 3. What about eligible professionals? Well, those who choose the MIPS program of MACRA will be required to adopt the criteria in advancing care information. That is one of the 4 components of the composite score that go into MIPS. And the best source for information on advancing care information is available at the link that's given here.
In both stage 1 and stage 2, the criteria, the specific objectives that needed to be met, were in 2 categories: core objectives, are objectives that everyone must meet, and menu objectives are selected from a set. So in stage 1, eligible professionals must meet 15 core objectives and then meet 5 out of the 10 menu objectives. For stage 1, eligible hospitals have 14 core objectives, and those 14 are similar to 14 out of the 15 for eligible professionals, and they too then must meet 5 of 10 menu objectives. For both eligible professionals and eligible hospitals, one of the menu objectives in stage 1 must be a public health measure. In stage 2, eligible professionals now have to meet 17 core objectives and then select 3 of 6 menu objectives, with eligible hospitals needing to meet 16 core objectives and choosing 3 of 6 menu objectives. Over the years, there have been timelines like the one listed here, which show when an eligible professional or eligible hospital first meets meaningful use and then what stage they need to be in subsequent to that. This figure was updated as the years for meaningful use stages 2 and 3 were pushed back, and this is the most recent figure that was released in 2013. This slide lists the core objectives for stage 1 of meaningful use. You see in the middle that there is one objective that does not apply to hospitals, so it only applies to eligible professionals, the generation and transmission of electronic prescriptions. But otherwise, these are the core objectives for eligible professionals and eligible hospitals for stage 1 of meaningful use. This slide lists the menu objectives for stage 1 of meaningful use. The upper half or so lists objectives that apply to both eligible hospitals and eligible professionals. There are then some measures that apply only to eligible hospitals, followed by others that apply only to eligible professionals. This slide shows the stage 2 eligible professional core objectives. If you drill into them and compare them with stage 1, you'll see that some are new and others represent upping the bar from stage 1 measures. This slide shows the rest of the stage 2 eligible professional core objectives. Here are the menu objectives for stage 2 for eligible professionals. This slide shows part 1 of the stage 2 core objectives for hospitals, which include eligible hospitals and critical access hospitals. And this slide shows the second half of the core objectives for stage 2 for hospitals. And finally, this slide shows the menu objectives for stage 2 for hospitals.
This slide shows the current timeline for eligible hospitals. As with all stages of meaningful use, what you are required to do depends on when you started. For current and newly starting eligible hospitals, modified stage 2 is required in 2015 and 2016. In 2017 is the option for advancing to stage 3, which will be required in 2018 and beyond. This slide lists the criteria for modified stage 2. There are a fewer total number of criteria categories, but each of these categories has more than one measure. I won't read through each and every measure, but we can see here that the categories include protecting patient health information using clinical decision support and CPOE, electronic prescribing, and providing patients with summaries of care that can be transmitted electronically. This slide lists the rest of the categories that are required to achieve modified stage 2 of meaningful use. Again, looking at the major categories, we see there are criteria around using certified EHR technology to identify patient-specific resources and provide those to the patient, performing medication reconciliation, allowing patients to download and transmit their health information from the provider, communicating with secure electronic messaging, and engaging with public health agencies. This slide lists the categories for stage 3, which are somewhat similar, though not identical, to those of modified stage 2. They continue the structure of having broad goals and then individual goals within each category. So we see that the categories here are, again, somewhat similar to those in modified stage 2, protecting electronic health information, electronic prescribing, clinical decision support, CPOE, and providing patients access to their records and patient-specific educational materials. This slide shows the additional categories for stage 3 of meaningful use. We see that the total number of categories is less, although many of the criteria have a higher bar to be met in stage 3. This slide shows a nice succinct table available at the link listed here of what's in modified stage 2 of meaningful use and contrast that with scheduled stage 1, which some providers who qualify are able to stick to. But this slide is best to give a very, again, succinct overview of what's in modified stage 2, of course, moving into 2017 and advancing care information for eligible professionals. Some of these measures will change.
Another requirement for achieving meaningful use is the ability to report on clinical quality measures, or CQMs. The particular CQMs changed in 2014, and the new measures apply even to those who are still in stage 1. So the prior clinical quality measures apply for any stage prior to 2014, and then the new measures apply to 2014 going forward, no matter what stage one is in. For eligible professionals, the pre-2014 measures required the completing of 6 out of 44 CQMs. 3 of these were core or alternative measures, and then the other 3 came from a menu selection. For eligible hospitals and critical access hospitals prior to 2014, there were 15 measures. Now moving into 2014, there is a requirement for eligible professionals to complete 9 of 64 CQMs, and there must be at least one measure in each of 3 national quality strategy domains. For eligible hospitals and critical access hospitals, there must be the completion of 16 of 29 measures and 1 measure in each of 3 NQS domains. This slide shows the CQMs for prior to 2014. The 3 core measures required for reporting were measurement of blood pressure, designation of preventive care and screening for tobacco use, and adult weight screening and follow-up.
If any of the denominators of the core measures was 0, then there were 3 alternative measures. One was weight assessment and counseling for children and adolescents. A second, preventive care and screening in the form of influenza immunization for patients 50 years and older. And then finally, childhood immunization status. And then again, the eligible professionals must report on 3 of 38 additional measures. This slide shows the CQMs for eligible hospitals prior to 2014. The 2014 CQMs are way more complicated than to fit on a PowerPoint slide, so further information can be obtained by clicking on these links here. The 2014 measure have an electronic specification, an eCQM, and this uses something called HQMF, and the terminology comes from a value set that's maintained by the National Library of Medicine. Beginning in 2014, Medicare eligible professionals and eligible hospitals must electronically report their data to CMS. Of course, under Medicaid, reporting is done at the individual state level. Recall that the 2014 measures need to have at least one coming from 3 different NQS domains. This slide lists the 6 National Quality Strategy domains from which the measures are categorized. How much money has been spent under the HITECH Act? This slide comes from CMS and shows over the years the total amount of money spent, obviously related to the total numbers of eligible professionals and eligible hospitals achieving meaningful use. But if we look in the very last column, we see that there has now been about $35 billion spent in the meaningful use program, and one can debate the value of that expenditure, although, as we'll see in the next slide, the adoption of electronic health records has increased substantially during this time. This slide shows various analyses that have been done on the uptake of electronic health records, and we see that it has been substantial during the time period of the HITECH Act, whether we're talking about office-based physicians, emergency departments, outpatient departments, or federal hospitals. The latter actually being the most successful story, with nearly all hospitals in the United States now having adopted electronic health records, even if all of them have not achieved meaningful use. For additional suggested readings on the topics covered in this lecture, I can suggest a relatively small and readable book called The Healthcare Handbook, written by a couple students from Washington University School of Medicine and now developed into a book and a website. This provides a basic overview of the U.S. healthcare system. For more supplemental readings, there are all of the various IOM reports, although clearly the Crossing the Quality Chasm report set forth the quality agenda, and there's also a report from the Institute of Medicine on public health.